I'm going to talk to you today about something that I strongly believe is urgent for us to consider in our roles as leaders in our local healthcare systems. What we saw, thank you, what we saw during 4CE was that we were able, because we had privileged access to the data at our own institutions, and we took that data very seriously, we were able to understand and debug the data in ways that national efforts that did not go down to the roots failed at. And so I can tell you that there were several large efforts, including those that was led by a company that sometimes does good work, Palantir, where the data was not good. It did not really reflect what was there because the mapping, the understanding of the meaning of these different data types was incorrect, something that we debugged in real time in that 30-day dash that we did at the beginning of 4CE. And the reason I bring that up is because we're now at the very interesting moment. This country probably does not have AI regulation at this point. The Biden executive order essentially is overridden. And in the current bill that's waiting in Congress, there is a attempt to prohibit regulation for 10 years at the state level. Now, I am, even in the midst of our budget, of our grant cuts, I am resolutely an optimist. And here's how I'm going to be optimistic in this respect. I think that the AI regulations were being made very abstractly and without an understanding, a deep understanding of the risks, but also the benefits and the actual details of implementing AI in large parts of our society, like the healthcare system. So for example, in the Biden bill, there was some bizarre limitations, like it was this many flops. If you were above this many flops, it was illegal. I was thinking, or not illegal, it had required additional oversight. And that seemed like a bizarre threshold. There are, I think, very important considerations and concerns. And my cup half full version of the current situation is to say, this is an opportunity for us at healthcare systems and for clinical leadership to actually say, for healthcare, what is the appropriate regulation? And for a long time, I want to point out that what was considered reasonable policy actually devolved from healthcare systems. We lost that will for leadership, and now we have it again. We have the opportunity again. What remains to be seen is, do we have the will? So in the next, where's Diane, 45 minutes? In the next 45 minutes, maybe I'll try to get in ahead of time so that I can have a dialogue with you guys. I'm going to try to tell you about a little voyage that I've had around what I believe to be the most important part of AI, which is, who is the AI working for? And I'll start with a lame, it's not a joke, but it's a tale from when I was in training. I was at a cocktail party in Cambridge, Massachusetts, and there was a shrink nearby me talking to a dentist. And they were talking about what they were doing that summer. And the dentist was talking about how they were going to be upgrading their boat so they would have a nice time going around Nantucket. And that the only possible fly in the ointment was whether they could afford it, but they had enough procedures scheduled that spring so they thought they would be able to afford that upgrade for the boat. That was slightly discomforting for me because that was my dentist. And just a few weeks before, he had suggested to me a very expensive procedure. And so the question I asked myself, of course, was what had motivated him in suggesting that procedure? And I'll put to you that we have to be asking ourselves that same question for all these AIs. Because in the end, transparency, schmansparency, explainability, blah, blah, blah. It's trust that drives our ability to put ourselves in the hands of our doctors. And our trust devolves from our belief, to the extent that we believe it, that their interests are aligned with ours. And this is the moment in time and history to ask ourselves the question and do something about it. And it's only those of you on the ground who are in position to help leadership of our systems do this. So now, let me jump right into it. Test number one. Bye. All right. So, first, I know the next three slides I think you've seen before, but I want to emphasize them. This first slide basically says, don't trust AI because medicine moves fast. In the middle of COVID, we were all worried that we were going to, no, at the beginning of COVID, we were all worried that we were going to run out of ICU space. Epic created a predictor of deterioration, which was to be used to figure out who goes to the ICU next because they're predicted to deteriorate. It was implemented based on a lot of data that they had in several healthcare systems, and it really was used. At the same time, others with Epic at Michigan used the algorithm, and if it was a perfect predictor, you would have expected, well, this to be a one-to-one straight line, but in fact, you see that dip. It was very poorly calibrated, and why was that? Because the case mix, the people coming in for care, were very different in Michigan than in other places. Partly because of the population, but partly because for that particular hospital, how patients got there, whether it was through the emergency room, through referrals, through regional flow, was different than those of the hospitals in which the training happened, and therefore, the probabilities of deterioration were quite different. So that was a little bit worrisome. And then 6 months later, all the models were not calibrated. And why was that? Not because COVID had changed, but because thanks to a RCT in the UK, we had a drug, dexamethasone, that actually worked remarkably well. And that changed the whole prognosis of it. And so what's the lesson here? The lesson here is, of course, that there's data set shift and that medicine is changing all the time. And if we don't recognize that, we've got a problem. However, our current regulatory system likes to freeze a widget, software as a medical device, and say that's what we approve. But that itself creates a bizarre paradox that we're not acknowledging that medicine's changing, our patients change with location and time, and in some sense, we're condemning AI to failure under that regulatory regime. I don't know if I've shown you this slide. This weird thing, which looks like some weird dysrhythmia, is in fact the weight of my mother. My mother had been admitted back 10 years ago, I think it was, twice in 6 weeks to hospital for, by the way, sound check, can you hear me? Had been admitted twice for heart failure. Came in with very, very tree trunk wide legs with weeping fluid from the transudate, from the hydrostatic pressure of the heart failure, really uncomfortable, not breathing well because her lungs were filling up. First time she was living on her own in their late 80s, and first time she goes back home, the second time she goes to rehab, and I knew at that point that if she was admitted again, she would die. And so I did something that would incautious at multiple levels, which was to get her a scale that at that time through Fitbit that had Wi-Fi connections, and these were the weights I would get. And every day I would check on her weight, and and this was without talking to anybody, which alarms I'm trained as a pediatric endocrinologist, which alarmed all my adult medicine people. And if her weight was up 2 days in a row by a pound or more, I told her take an extra dose of Lasix, of a diuretic. That's it. And that's my mom. And what was amazing is her legs became thin. She never got admitted to the hospital again for heart failure. She was perfectly tuned up. And here's the thing, as someone who's worked in informatics for 30 years, I knew for a fact that what I had done in the randomized controlled trials did not work. It had been shown many times. I was not the first person to think about, let's weigh someone to see their water balance, but it had not worked. So I wrote an article that appeared under something called Common Health, which was part of our local NPR station, WBUR, what my 90-year-old mom taught me about the future of AI in healthcare. So this was, at that point she was 90, she had gone through this, and she was fine and fully autonomous. And I made the following points. A, in the kind of setup that I've just described, who oversees process automation? Who makes sure that everything is installed and works? Me. Otherwise, someone has to pay for someone like me. Who completes the loop? Who goes from what my mom did and lets the healthcare system know? Me, or a healthcare professional. Who is trusted? Well, her MD PhD son would tell her to take a pill, and she would argue with me several times. And I can tell you, I had to go into the level of threats at some point to make her do it, because she was appropriately suspicious about medicine, even that of her son. But she did it. But I really had to weigh in. Think about what that effort that would take of a professional, not her son, to do. And what would likely to happen? Oh yes, it would not happen. And who integrates it with the rest of care, aware of all the other medications? That had to be me. That's a lot of oversight. And some of this is automatable, but a lot of it has to do today with trust and an ecosystem that does not exist. And yet, I strongly believe that we have no choice now but to move forward and say, given the failures of our healthcare system, I don't know if I said this last year, but here in Boston, at our finest healthcare system, Mass General Brigham, you cannot get primary care. The primary care practices are closed. Residents at MGH can't get primary care. My faculty can't get primary care. If you're willing to spend $6,000 to $10,000 a year, you can get concierge service. So we have to actually start figuring out how we use this new facility this new utility, AI. And I want to point out that I'm going all in because even in this journal that we started, when we first started the journal, the editor of Science said he would not accept any submissions if they had used a large language model to write it. And I had, with our editorial board, had a conversation where we decided, listen, we're not a literary magazine. We're not looking at the quality of the text as a measure of whether we're going to publish it or not. We're looking at the quality of the science and the meaning to the medical audience. And if someone, especially if they're not a native-born English speaker, will be a far better communicator of that science if they use one of these models. And I just bring this up to say that there are multiple parts of our establishment, our biomedical establishment, that for no reasons other than this is the way we did it, are reluctant to move forward. And by the way, 3 or 4 months after we said it, Science reversed their policy. I'll also remind you that things are moving fast. And this was the performance of the various AI models, in this case the Google models, but the same curve is shown for the OpenAI models, that in 3 years, they went from being worse than any medical student in the United States to better than 90% of medical students taking the medical boards. And yet, there started becoming concerns that were said out loud. We're running out of data. Remember, these models used everything available on the internet, which, by the way, includes about one-sixth of that corpus includes medical stuff, because we, doctors, are very driven for right and wrong reasons to publish. And so through various online sources, we actually comprise one-sixth of the content. But we had run out of it. And there was an argument that we had saturated, therefore. Well, let me fast forward to this slide. This is a slide to remind us that we had not saturated at all in terms of the data. In 2020, there was a Nature article where they paired echocardiogram reports to echocardiogram video and trained up a model to generate that text from the video. And it worked with about 10,000 or so reports and video pairs back in 2020 and appeared in Nature. 4 years later, we got to 1 million echocardiograms. And that process, it's behind. Anyway, that process was published by colleague David Ouyang and others, and it's at the expert level of a cardiologist in identifying gradients, identifying structural disease, and this is because the scaling law continued, and most of what we have in our electronic health records, in our healthcare system, is not in these large language models. What's mostly in these large language models is the published literature. It's not the data. So in terms of data size, we're far from saturating. Which leads me to the following human expertise AI paradox, which is that which we as humans and doctors most value, highly technical interpretations of a genome, of an echocardiogram, of an EEG, are the easiest for AI to excel at. The things that AI does not do well, and it's also true of zebra diagnoses. If you give the CPCs, the clinical pathology cases from the New England Journal of Medicine to ChatGPT and its brethren, it does great. If you give it a common case seen by a primary care doctor does not do great. It does not know all the commonsensical things that go into assessing how well they're doing, how they're walking, how they're eating, what their mood is. And so, paradoxically, what we value the most, AI does the best. And paradoxically, what we value the most, we pay for the most. Whereas primary care is not valued, it's not paid highly. Doctors are not going into it, despite many National Academy of Medicine groups, where it's tanking. As a nation, we will be at a deficit of about 50,000 primary care doctors within 5 years. And by the way, the fundamental is independent of our fee-for-service system. I just said it's true in France and in the UK. Nobody wants to go into primary care, and those who do, for example, in the UK, are out of it, for the young ones, in less than a decade. And so we're in this bizarre situation where AI is going to be able to replace or accelerate the stuff that we most value, but the most important gatekeeping preventive medicine function is least, I think, amenable to full implementation with AI. And I think this will become even more apparent when we understand that some of the foundation models, so these are models where it's not just can you generate the next word, but it's having all these interconnected data and asking a variety of different kinds of questions. Like in this Nature paper, for example, this Nature paper done by one of my colleagues, Kun Sing Yu, and collaborators over, I think, 24 countries, looked at cancers of all stripes, of all kinds, and they had, in irregular fashion, immunohistochemistry, genome sequencing, trial data, annotations. So, but not complete. But nonetheless, over all these different cancers, this foundation model could, in fact, then, at an expert level, outperforming the specialized models, identify the cancer cells on the H&E standard slide, could actually predict, based on the morphology, the mutations, predict for the individual patient likely survival, could find the margins of the tumor, and even suggest which therapies are the most likely. All this. So this is, in some sense, the power dream of the pathologists. And this is saying, as we scale up with these data types, we're getting closer and closer to that. Okay, let's move on. So now I'm getting closer to where I wanted to talk to you. This interesting painting is of Dominique Jean Larrey, a French military surgeon. And he changed medicine. And it's sad. It's not sad. It's a reminder, in case we ever get hubristic, of how important people are lost to history. This guy changed medicine forever. In the Battle of 1807, he brought to bear his techniques that he had developed of triage. What had triage been before? Rank. The more senior you were, the more attention and the sooner attention you're going to get from the medics. Here, he said, no, we are going to prioritize those who are wounded in ways that we can rescue them. First, we go with the people that we can rescue the most, And then we do comfort measures. And what I want to point out, this breakthrough in medicine was fundamentally a change in values. It was recuperability of the patient over rank. A fundamental shift in medical values. And by the way, the outcome data were immediately super impressive in that regard. I want to contrast that with some of the values that we see in medicine. I will say this out loud in case, and this is a very American-centric thing, so forgive me. This new drug can cause memory loss, but only about things concerning the Sackler family. And this is a point made that many of us, essentially, were manipulated into overprescribing narcotics at a great cost to our nation and to the world, actually, because we did not have the right values driving us, and we have to be careful about that. So perhaps the most impressive use of values in real time in healthcare is out of colleagues in Israel. The Keynote healthcare system have this, Keynote is the largest HMO, health maintenance organization in Israel. It's responsible for half of the population, Arab, Druze, Bedouin, Ashkenazi Jewish, Sephardi Jewish. And on these 6 million people, it has comprehensive data going back decades. And they've developed this CPI system. And what does the CPI system do? It looks at a panel of patients. And by the way, unlike us, they will actually pay the full, if I'm a primary care provider, I get paid the full amount I get paid to see patients, just to look at the same hourly rate, just to look at these panels. To do what? To decide who am I going to see tomorrow or next week. And what it does, to help you do this, it actually looks at the details around each patient, and they look at 3 patient components. Risk for the outcome they're trying to prevent, like diabetic complications, the patient's life expectancy, the more life expectancy, more to be lost, and the significant quantity of care gaps. What care gaps exist? So the combination of those 3 is what drives this algorithm, who should be seen next. Now, it turns out it's extremely contentious about how you weight those different algorithms, because those are fundamentally value judgments. But they're really doing it. So now we're getting a lot closer to what I'm trying to tell you about. So this is a paper I published with several of my colleagues, led by Arjun Manrai, in the New England Journal of Medicine, called Medical Artificial Intelligence and Values. And we pointed out that in AI, values get inserted at many levels. Just to give you 3 levels. One, you've heard ad nauseum about bias in the data. So data is where a lot of the values come in. Then how the model is constructed is a second place that the bias comes in. But third is how the model is actually used, and that is underestimated as a lever to change values. And in the paper, we took an illustration that I remember from my practice 35 years ago. You have a child, a 14-year-old male, who is short in the 10th centile, not pathologically short, but short. And workup is normal, but they have lowish, but not scratch out, growth hormone. So we asked GPT-4, when we wrote this paper, what should be the right therapy for this patient? Should they get growth hormone? But first, we told GPT-4, you're a pediatric endocrinologist. And it said, definitely give growth hormone. Then we told it, you're working for the insurance company. And it said, definitely don't give growth hormone. And I want to point out that actually the scientific rationale for not giving growth hormone in this case was better than that of a pediatric endocrinologist. Because giving growth hormone to non-growth hormone deficient children is not a clear win. I can go into details for you afterwards. But here's the point. Just by changing the prompt, we did 180 degrees. Remember, in bias, we're talking about shifting slightly how these things work. I'm talking about 180 degrees shift in the decision based on a prompt. And you can say, Zach, but that's your prompt. But remember, there's a whole bunch of system prompts that we don't see, including don't let the patient kill themselves. Don't let, if I want to try to kill myself painlessly, most of these models have prompts to prevent me. Don't make a pathogen. Don't develop a new pathogen to kill off the world. It'll try to prevent that. So when I first started saying this, I got, Zach, you should up your medications on your paranoia. How is this going to happen? I said, well, there are billions of dollars at stake. Just this growth hormone decision alone is tens of thousands of dollars a year per patient. But in healthcare, there's billions of dollars at stake. Do you not think someone's going to put their thumb on the scale? Well, I didn't have to wait long. There are now class action lawsuits against several of the insurance companies who have replaced human professionals who themselves may be biased, but not in a systematic way, in deciding whether to authorize or not referrals or procedures. Now they've been replaced by AI. And so there clearly is a value judgment implicit about whether or not this person should get a referral or this procedure. And now there's class action that patients have been unreasonably denied this. So this is not some future paranoid fantasy. This is happening today. And so that's in the payer space. If you don't think this is happening in the provider space, you're deluded, because we already know that among the biggest tools that are being sold for use in the provider side is AI upcoding. And that in a constrained resource situation, that's going to be a real problem. Zeke Emanuel is a colleague of mine. We both founded many years ago the Center for Outcomes and Policy Research at the Dana-Farber. And I've followed him in his meteoric career since. And he wrote with Dr. Prasad a very interesting piece about making decisions under scarcity. Now, the fact is, we always make decisions around under scarcity. On the battlefield, things are very scarce. We don't have a lot of resources and a lot of doctors. But even in Boston, we don't have a lot of primary care doctors. We don't have infinite dollars to pay for all the resources. So we're always making decisions on uncertainty. And what's worth looking at is the various frameworks that they talk about in this paper that guide decision-making, some of which I think might be slightly offensive to us until we think it through. Like, for example, it turns out that under certain ethical regimes, infants fall behind, are less valued. If you had resources, infants are less valued than a teenager. Why? Infant may have a lot of life years ahead of them, but they haven't had any experience. Their full humanity is not there. They haven't had any experiences, whereas a teenager, arguably, might have it. And what about, And then there's, what about important people? Shouldn't important people important to society, get better or more privileged care if they're important to society? That seems extremely offensive to me. But then I'm reminded, during COVID, we said doctors on the frontier who are taking care of patients should get the vaccine before everybody else. They're more important to society. These are real decisions that we do have to make. And they become more acute and more painful when the scarcity is higher. And so my first call to arms is that we need both a normative model and a personal model. Because what I mean by that, what we decide for ourselves may not align. We might have different values. Different societies, for example, value life differently in the context of pain. Euthanasia rules are different in different countries. Some doctors, for example, have different views about when's the time to call it a day in the ICU. And some families are more in that direction, and some families will say save them at all costs. These are different values. And knowing what those different values are is important. At the same time, this can't be a purely populist thing. We can't let everybody decide because we do have scarce resources, and a society has an obligation to steward those scarce resources. So there's absolutely going to be tension between the values of a person who is waiting for our heart donation for their failing heart about who deserves it more when there's only one heart available. These are real decisions that are made today. What do we know about the preferences of large language models? We know very little. We don't know which data was used to train them, by and large. We don't know which models out of the box are best aligned with our values. We don't know how consistent they are. When I talk to a doctor twice, it reassures me if they say the same thing to me upon a revisit. If they keep changing their opinion about what's good for me, I'm also a little worried. We don't know how well these models can be pushed to our values. And we don't know if they can represent the values of all parties. So we actually don't know where in the multiverse of medical decisions their decisions most resemble normative, that's the normative ethicist model for society, or particular patient context. So let me give you, I was frustrated by this and by this lack of knowledge, and I said, let me begin to understand what the problem is. And so this was a delightful study for me because I've gone to actually it's been true for the last 15 years that all my students think I'm way too slow, even some of my junior faculty. And when I start doing something, out of kindness for me, they say, Zach, let me take this, I'll solve it, and then we can publish it. I didn't tell anybody about this so I could get it done myself, so I could have the fun. And basically, I wanted to understand the concordance between an expert gold standard and these AIs. Having only myself and as a resource, I actually became the gold standard. And the gold standard was I developed through GPT-4 200 pairs of patients. And I asked myself for those 200 pairs of patients, which patient will I see tomorrow? And which will I say they have to be seen next week? If they don't, and they can choose to go to the emergency room, but I'm going to see them next week. And I went through these 200 cases. And then I gave the same task to 3 different large language models. GPT-4o, Gemini, and Claude Sonnet. And it doesn't matter the details except to say that they were not the same. They were not all as concordant with me as each other. And they also varied. They were not all as consistent. Let me explain the consistency part. Here is, I have a name here. Wait. So 3 runs of Claude, 3 runs of Gemini, 3 runs of GPT-4, and the gold standard me. And then it's the same thing on the y-axis. So if there's high agreement, as you'd expect, everything agrees with itself. So that's the high concordant red on the diagonal. And what you see is that up on the over there, there's less concordance with me by GPT-4 than there is, let's say, by Claude. And not only that, but GPT-4 is not consistent with itself, as shown by the blue. That's negative concordance. So what you're seeing here is that some of the models, like Claude, are very consistent. And after the fact, I found out that one of the trainings of Claude is to focus on consistency. But GPT is not. And then I tried various ways of aligning these models. I said, for example, maximize quality adjusted life years, or give precedence to age. But the one I'm going to talk about is, I said, here are 10 patients, 10 pairs, and here's how I decided. Use that decision to help you in your decisions. And so I'm trying to align the model. And it's fascinating. So what you see here on the left is what I'd shown you before. Here's after I gave it those examples. And look what happens. GPT becomes much more aligned with me, the examples, and more consistent with itself. It takes direction. Claude loses its mind. It becomes less consistent with me and less consistent with itself. Unexpected behavior, not particularly well explained by anybody to me. But we don't know these things. Should we not be systematically assessing this kind of both concordance with our gold standards? And obviously, it's not just my gold standard, the richness of all decision making. I will spare you the math, but I developed a few metrics of concordance and alignability, and across many types of alignments, and I created something called the Alignment Compliance Index. But again, I won't spend time looking at it. But here's the point. I published this in something that I'd never published before, at least as a first author, as a sole author, Archive. It's a computer science preprint place. I just published it. And then I got invited to a bunch of small conferences that you've never heard of. And I started talking about this. And because I am who I am, I said, how can I generalize this? I created something called the Human Values Project. And what is the Human Values Project? It starts with this clinical decision dynamic study, which is doing what I just showed you, but at scale. In other words, across hundreds of different decisions in different contexts, having hundreds of doctors of different types in different countries show their decisions. And then there's the normative decision guidance, which is a bunch of ethicists deciding for those same cases what is the right decision and why. And then over there, the benchmarking for those decisions. How do these different large language models, and a much larger set, how well do they work? How do they align? And then how well do they work out of the box? And then how well can we align them? So that's the Human Values Project. And like I said, I showed this in 2 very small conferences. And paradoxically, I got a lot of attention through happenstance. One is that OpenAI decided this was a really interesting thing. And while all my other grants that got shot down, we are richly funded by OpenAI to actually do this at scale worldwide. Also, Epic heard me at one of these meetings and said, we are very interested in this, and we want to look at our data with you to actually figure out not what doctors say they prefer in these, but setting up the very same questions, but looking at close matches to those decisions in the actual data to see what doctors actually do. So we're down to my 3 more slides. So first of all, I want to remind you where this values conversation started. It started at the battlefield. But in the modern world, we actually have 50 years worth of studies of human decision-making before AI, in which we try to elicit what the values are of humans in decision-making. This is, Kahneman and Tversky's work and others. Amazingly applicable to how we think about these large language models. Because, by the way, they show many of the same cognitive biases, or the similar behavior to the same cognitive biases that human beings have. A warning to myself, which is, whenever we look at how AI behaves, we always compare it to the best doctors, the way medicine should be. But I would like to argue, as I did in this NEGM editorial perspective, that we really have to start comparing it to the medicine we have. When in Boston, if you have or in the United Kingdom, where you have to wait 6 months to see a primary care doctor, and you're in pain, or you have a serious ailment, but no one's going to look at you, asking how AI is going to impact relative to that situation is a very different trial than saying, how does it perform compared to the best AI could be? So let's actually start having trials comparing to the medicine we have, not the medicine we would like to have. 2 more slides. Why should the i2b2 academic users community care about the Human Values Project? Here are 5 reasons. And Diane, are you going to share the slides? Good, thank you. It moves AI-driven informatics from can we predict to should we recommend? Something that I think is central, and you are all very well placed. It turns everyday scheduling, triage, and treatment choices into shareable research assets. It creates a cross-institutional testbed for evaluating large language models to see if the values are, in fact, consistent and understand the clinical trade-offs. It also anchors equity discussions. Are we actually being equal in the opportunity we're giving our patients to get better? And it also gives very rapid feedback for governance pilots in a situation where there's, in the United States, no guidance at this point, and everybody's waiting for stuff to happen. You are tip of the spear. We can make it happen by example. And I should say that in the country, it is in Europe, where it's overregulated, and they can't actually decide anything about values for patients because they're too worried about risks. So how can the i2b2 community get actually involved with the Human Values Project? One is you can actually field some of these reviews, these questions that we have online locally. You can see, how do your doctors of various stripes do? You can donate de-identified vignettes, important decisions. I was at the SAIL meeting in Puerto Rico, and all of a sudden, I now have leaders in France and in Canada on international organ donation policies, which turns out are completely rigged. When doctors want this particular patient to get the transplant, they'll bump up the platelets so that they qualify, or if they want another patient, maybe they'll bump down the platelets or let the platelets, not transfuse. So putting systematic preferences in here, and you can benchmark different large language models, because there's a profusion of these large language models. And you can benchmark them for these decisions. And you can join the alignment group that we're putting together. And with that, I'll thank you very much. And I think I ran out of time. Diane, much as I'd like to field questions, don't I have time? Fantastic. All right. So I think I've been a little bit controversial. So there should be a lot for you to disagree with me. If you have a question, please step up and ask the question. Sandy, it looks like you're going to ask a question. Excellent.
So this may be a trivial question, but I'm really interested in your thoughts on it. So if we had an AI clinical decision support algorithm where we could measure both, we could compare it. We knew how well it would perform relative to standard of care.
Yep.
Should our metric for putting it into use be improvement to standard of care? Or should it be some other metric? You know, thinking in this context where we don't have all the regulations, we want to optimize for the future, we want to optimize for trust.
So that's not a trivial question. It's a fundamental question. And so, for example, I can tell you in my role at NEJM AI, here's what I'm hearing from various people who are submitting articles. And it goes something like this. Wow, I thought the software as a medical device certification by FDA was going to be important for our AI. Doesn't seem to matter, because it doesn't seem to affect whether a payer is going to pay for it or not. And so the question is there actually a value being delivered? So, and I'm going to get to the specifics of your question. So let's say you're in a Boston hospital and you want to show that there is value. There's basically only right now, because we're in a fee-for-service system, there's only two ways that you can get someone to care about it. One is if there's a quality metric that you can prove, and in that case, the standard of care is not the theoretical standard of care, it's the real standard of care. And you actually run a trial and you show the quality improved with this product. It doesn't have to be the perfect way that medicine should be done. You just have to show, but there's only one way to do that, and that's prospectively. No retrospective study will ever show that. And the second is to show that it actually changes costs to the payers. And again, that's not revealed by the software as a medical device evaluation. That again requires a trial. Now, sometimes it seems so obvious that you're going to save money. In reality, everything that's been ever based on retrospective studies, I cannot remember of one instance where it's actually ultimately saved money because of the nature of the system. And I should just finally point out that the most amazing adoption, faster than any technology in the history of medicine, information technology in the history of medicine, is the use of something that the payers don't pay, but the hospitals are paying out of pocket because the doctors are demanding it, and that's ambient transcription. And so there's a few lessons there. Yeah.
Two quick questions. First
Yes.
of all, partly for Diane, is the set of exercises tomorrow relevant to learning about how to apply your scheme here?
No.
Okay. Maybe it should be next time.
Yes, next time.
Second question, can you summarize what you took from the little exercise we did and published on going through with AI and looking in records to see if obesity was classified by credible criteria and what kinds of defects we found in the records and in the interpretation.
Right. So my answer is going to be biased by the fact that I am a cup half full guy. And so we used the 4CE data to look at obesity in the context of, so obesity is a pandemic also, in the context of another pandemic, COVID-19. And to make a long story short, we were able to do a lot better with the textual data than just the codified data alone in multiple languages. It worked remarkably well, in my opinion. There were some things that did not appear because we didn't have all the textual records, and because in most of the world, unlike the Clarite system I told you about, if you have data from the hospital, all you have is data from the hospital, that patient's data may be spread over multiple hospitals, and so you don't have a complete record. And then, yes, there were some languages are better covered by these models than others, so the performance in different languages changes. But I'll tell you, so there were limitations, but here's what my take was, that if the WHO or somebody who is responsible is not taking this approach for the next pandemic and saying, we're going to actually instrument at least a few sentinel hospitals to have this kind of access for an AI to the textual records so we can actually describe in detail
Real time.
the course, we're making an incredibly irresponsible move forward. Someone needs to write that editorial, and someone like Gil Oman, who actually works in these rarefied levels, should be telling WHO that's what we should do. All right. Any more questions?
Switch over to the panel
All right.
that you're moderating.
Everybody come up for the panel.